And first of all, I should appreciate Dr. Darby for your pioneering work, and your work has profoundly influenced our understanding of this ROCD. This is Dr. Rezaul Hamid, a private practitioner from last 20 years. Basically, I'm a learner. So I have gone through that your details of works. This is the first time actually I came to know about this term ROCD. Once the company, I should appreciate the company who has invited me to be one of the panelists and forwarded me most of his works, and I tried to comprehend what you mean to say and what new thoughts that you are trying to unearthing in understanding these very complex areas of this OCD spectrum, whether I should say, which is one of the most crippling, disabling, and very weird form of, if I comment, this is one of the most misdiagnosed. This is also a misdiagnosed. So your work has definitely unearthed a new dimension and has guided us to think more beyond. This ROCD, actually it helped us in understanding this intrusive question. And if I say that, do I love enough? And whether this my partner is right for me. And it reflects this metacognitive confidence, whether these thoughts, feelings are consistently examined instead of trusted. So I want to know, are you intended about planning to find out the biological correlates of these conditions?
The what?
Biological correlates. Getting the fMRI, PET or SPECT and correlating with this.
Right now we don't have such plans.
Okay,
but,
okay.
But maybe someone here listening to this lecture can.
Well. What about the quality of life those the patient diagnosed to be having ROCD?
So generally, I think one of the questions that we ask clients is, is it interfering with your work, social, and potential? These are the three questions.
Okay. Have you taken any specific tools for that, assessing the quality?
And a lot of times people report that their quality, if you're preoccupied, 6-7 hours a day with your relationship,
okay,
this is not a good quality of life. And a lot of times when clients actually ask about prescribing medication, what I tell them this is a question of quality of life. Is your quality of life good enough as it is? And for a lot of patients with OCD, if they are having severe OCD, for example, the quality of life is poor, and it's Sisyphic to continue.
But I was not able to get some clarities on various other conditions, like that is the delusion of jealousy, Othello syndrome, and this frequently it can create creates a confusion in understanding this ROCD. And here I could find that your sample sizes were a bit low, and mostly it was relied on the self-reporting measures. So on that, actually, I would like to have some clarity on that. And further, I'm also a bit confused about this OCPD and how we can differentiate that. So I'd be expecting some clarities on this. Usually the role of enduring personality structure, especially the OCD traits like rigidity, perfectionism, interpersonal control, and that may basically scaffold these ROCD vulnerabilities. Thank you very much.
So thank you. So first of all, I would say, we started actually by interviewing people, not by having measures.
Okay.
Initially, when we started in 2007, and we started by interviewing people. We interviewed around 100 people who were self-reported ROCD sufferers. And from the interviews that we made with them, we actually got the measures, because we saw only one presentation or two presentations in the clinic, and then we started interviewing people and actually learned about their experience, and from their experience we developed the assessment tools. So, and true, most of the studies, and these are the limitations also of the studies, most of the studies have been studies that have been done on self-report measures. There are some studies that use the MINI or the Diamond as an assessment tool. So it was assessed by by a structured clinical interview.
Wow.
And it met criteria for OCD. We had one study, right now I don't remember if it was published or not, but we actually used a version of the Y box.
The Y box.
So we did the scoring, and with specific questions about relationship obsessions. So these are, and I must say, this work is in the beginning. It's not the end. It's we started in 2007, and throughout the world and different cultures. We started in Israel, and then we had people who collaborated with us from Italy and from Turkey, and actually researchers from Iran and Pakistan. So different countries, Ethiopia, Albania. So we have different countries that these measures were translated to and were used in different cultures. And I can say I also had the experience of consulting with clients, actually from India, from Iran, from Mexico, different countries that turn to us. And the presentation is very similar between cultures, which is quite amazing.
Yeah, actually that validates his biological origin. Actually, I asked this question from the Indian perspective. Actually, in India, 90% is the treatment gap. And for OCD, actually, I do not have any specific data, but I can assume that this is very colossal. Actually, whenever the patients and all my fellow psychiatrists, they will also be agreeing with me regarding the level of dysfunctional that we get in the patients of OCD. Anyway, this was a great learning experience for me, and it has unearthed a different, another new dimension of thinking. Thank you very much. I appreciate.